Some of the common terminology you should be aware of, and I think Mary probably went through some of this stuff when she talked about disinfection, but an antibiotic is basically a drug that kills any microbial growth. The pathogenic origin, the pathogen is the actual thing that's causing the disease. It should probably be a disease hyphen causing microorganism. Change that. Empiric. The term empiric talks about if I have a patient who comes in with a infection, a pneumonia, and it was a community-acquired pneumonia, meaning that was just one of you who all of a sudden developed a pneumonia, presented to the ER. Before they could get the culture and sensitivity back, they would start you on an antibiotic empirically, meaning, man, the odds say that this is going to be a streptococcal pneumoniae. So let's go ahead and use an organism that's responsive to that organism. Then if we get the result back and it's something else, then we can switch to antibiotics, but I've already started you on something to get a jump on it. That's what the term empiric is. It's basically based upon precedent and prior experience. Okay. Normal flora, we know, is the stuff that's growing with us, within us normally, and we're living symbiotically with it. In fact, if you don't have them, you can actually run into problems. And the term aerobic and anaerobic you should know from micro. Gram stain is the process by which we determine if it's gram positive or gram negative. The term culture and sensitivity is basically, again, identifying the organism and finding out what it is susceptible to. And you should be able to distinguish between bacteriostatic, which inhibits replication and growth, and bactericidal, the CID, implying that you're actually killing it. And broad spectrum versus narrow spectrum has to do with the relationship of certain antibiotics will work on a wide range of organisms, or fighting a wide range of organisms. Narrow spectrum are much more narrowly related. For our purposes, you should know from micro days some of the more common gram-negative being Pseudomonas, Haemophilus, Klebsiella, Legionella, Mycoplasma. Actually, Mycoplasma, you can argue, is not even a bacterium. What's that? Pseudomonas, Haemophilus, Klebsiella, Legionella, and Mycoplasma.
God, I hated that class.
And on gram-positive side, Streptococcal and Staphylococcal. So both those two. The other ones, although they're important, you won't see as much involved, but yeah. For right now, let's not worry that much about some of these antibiotics as far as how we classify them. Narrow spectrum, broad spectrum. I just want you to know that there's a difference between them. Okay. When we get to the pneumonia, I'll delve a little bit deeper, but for right now, don't worry about it. Unless I'm telling you to worry about it, don't worry about it. Don't worry about it. Okay, there's a bunch of classifications of drugs that are there, and again, we'll talk more about them, but you can see that basically each of the categories has become a little bit more intensive as far as how it works. For right now, the classes of antibiotics that we're going to be concerned with, and again, there's multiple ones here, but what we're going to worry about, number one, is this drug Tobramycin, since this is one of the antibiotics that we are responsible for nebulizing. It's used in the treatment of cystic fibrosis. It's part of their normal management. Because they have usually a variant of Pseudomonas aeruginosa there all the time. Okay. Trade name is Toby. Should know that. It's one of the drugs you will need to memorize for the final. That's 300 milligrams and 5 milliliters, given one vial BID, and it's on a pattern of 28 days on, 28 days off.
Forever?
Forever. Okay. It's a little bit of a difficult drug to administer because of the viscosity of the medication. So one thing you'll want to do is you'll want to give a bronchodilator prior to administration of the drug, and the second thing is you need to use a specific nebulizer. And that specific nebulizer, one of which is the Peri LC+. Okay, so these are, it's a very specific, and the reason why you need a special nebulizer is because it's so viscous. Traditional ones just will clog up.
What's it called again?
Peri LC Plus. I was going to say that, but that's okay. The other drug you should be aware of is what is known as colistin, colistimethate. It basically works in those patients for whom Toby is not eradicating or keeping under control the Pseudomonas strain that is present. Okay. And again, it should be used pre-treatment with a bronchodilator. And the dose is 2.5 to 5 milligrams per kilogram per day, given in 2 to 4 equal doses, so given either BID or QID. Right, Tobia is not keeping the Pseudomonas infection in check. Usually Tobramycin does, but because these people have these infections for so long, they can develop variant strains that don't always respond to Tobramycin. Okay? And you should be able to memorize all this and know. No. Peri Plus?
Yeah. Can that be used for albuterol?
It can, yeah. You really shouldn't mix them, though. Just give a treatment with a bronchodilator first, then use this one.
No, I'm saying that specific.
As far as I know, you can use it for that purpose, yeah. I can't remember ever running across anything to the contrary.
No.
And we'll again cover this a little bit more in depth when we get to the pneumonia part. Antiviral agents. We know that there's a lot of viruses that are out there. The more common ones we're worrying about is the influenza vaccine. I'm sorry, the influenza virus. And the antiviral agent that we're going to use, or let me back up. The two that we're going to talk about, an antiviral agent called Ribavirin and an antiprotozoal agent called Pentamidine. Although Pentamidine, or I'm sorry, the Pneumocystis carinii, that organism, we're not sure what the hell it is. We used to think it was a protozoa. There's now that some feel it's a unique form of a virus. I'll talk more about both those drugs in a second, but let me just talk about Ribavirin first and what I want you to know about it. Trade name is Virazol. This is the drug we're going to use with that SPAG. So put in your mind together Ribavirin, Virazol, SPAG. We used to use this drug all the time for RSV infections. Now there's a better way to do RSV management. However, because patients that are immunocompromised can still develop RSV infections, not a bronchiolitis like you're going to see in a newborn or an infant, okay, but rather an immunocompromised person, somebody who's either bone marrow transplant or has they're immunocompromised for some other reason. They'll end up using this drug prophylactically, or I'm sorry, using this drug with a SPAG to treat those infections. Okay? So bottom line is the majority of the time you'll never see this thing used unless you're working in a transplant center and unless you're working with immunocompromised patients. Remember, with immunocompromised patients, what ordinarily we wouldn't even have any problems with, our body would naturally fight them off. They can't. Okay, so that's what it looks like. You don't care. This is some side effects. You don't care. This is talking about the American Academy of Pediatrics saying we're not going to use Ribavirin as a primary mechanism to treat respiratory syncytial virus and bronchiolitis. Okay? Unless they got some of this other stuff, but for our purposes, we're just going to ignore it.
So you're going to use the SPAG for the bronchiolitis pneumonia?
You're going to use the SPAG to deliver the drug, Ribavirin, and we're not going to do it for routine management of RSV and bronchiolitis, only for those patients who have immunocompromised viral infections. You don't need to know this because it's a drug that's given by IV, but this is the drug that we now use to treat RSV. This is RSV season. We're coming up on the end of it. It usually runs somewhere between November and March. And hand washing, hand washing, hand washing. This is a very communicable organism. It loves to just hang around on surfaces. Well, I shouldn't say hang on surfaces, but it's airborne and it's very easy to transmit. Don't worry about this for now, but when we talk about influenza, when I talk about pneumonias, viral pneumonias, this is the drug that we'll end up seeing. Tamiflu is probably one of the more common ones that is utilized for treatment of that. All right, so that's Virazole. Okay, the other drug that is kind of a weirdo is Pentamidine, known as Nebupent or Pentam. And this is used to treat a pneumonia that is caused by this odd little organism, Pneumocystis carinii. It actually has a new name, which I don't have in it. It's Gerovese, but we'll talk about that when I talk about pneumonias. But again, it's an opportunistic organism. You and I being exposed to this would have no problems at all. Patients who are immunocompromised, very commonly seen. In fact, the patients who had the biggest incidence of PCPs were patients who had HIV. I don't believe we have to know this drug. Yeah, I'm pretty sure. No, I'm pretty sure I took it off as far as a drug that you would end up knowing. I haven't told doses of it. This is one we would use, a Respirguard nebulizer. If you remember the Respirguard, that's one that you don't have to worry about that. I'm not going to ask you a question on that. But Respirguard is one that you have a filter on it. Remember that? You filter the exhaled gas because, yeah, you don't want it. I won't ask you a question about Pentamidine specifically, other than that it's used for a PCP infection. And I may not ask that till we get to the pneumonia part, but I reserve the right. Antifungal agents, again, they happen in immunocompromised patients. The exception being Candida. We'll see in a patient who is an asthmatic who's not using their inhaler correctly, or not using their, if we're talking about using a nebulized formulation of Pulmicort, not clearing the mouth out, you can end up with a oral thrush due to Candida. Okay. There's a whole slew of fungal infections that we'll come back and visit, and we'll find that amphotericin B IV is the most common mechanism. Nothing that we're going to deal with, so for right now we'll just let it go. TB, same thing. I'm not going to expect you to know for tuberculosis right now, but recognize that when we talk about tuberculosis, we will talk about that there's various frontline drugs and some second-line drugs. And the regimen for using TB is that there is usually 2 to 3 frontline drugs that are given simultaneously for a period somewhere between 6 and 9 months typically. So being positive for TB is no fun. And we'll talk more about this when we get to TB. Lidocaine, all I want you to know is that can be used as an anesthetic agent. We do it for topically for before intubation. You can use it before bronchoscopy, before chest tube insertion. It can be used as a local anesthetic, and also be used as a local anesthetic for blood gases. I think Mary may have talked about using lidocaine. Okay. Don't worry about the dosing for it for now. It's not one of the ones I'm requiring you to know, but it is available as a 2% solution. And lastly, let me just spend a little bit of time talking about nicotine replacement therapy. Okay, we know the reason why. Well, we know what it is. It's part of the smoking cessation program, and hopefully next year I'll have you I'll have a person come in who goes through some training so that you can become a smoking cessation. You will become a smoking cessation counselor. Smoking cessation, not sensation. No. We know that smoking is quite prevalent still, at least 25% of the population, and in some geographies at least. It's a highly addictive agent with multiple relapses occurring, and it's kind of always been the American Lung Association's little saying is never quit quitting. Always attempted to try for it. If you look in your text, there is actually a survey that can be done. It's called a Fagerson test that basically looks for nicotine dependence, and it asks things like, when is your first cigarette of the day? How long can you go without having a cigarette? That kind of things. Okay. And what's important for us is that we got these folks under captive audience. There's not much you can do when you're in the hospital, so it's a great time to initiate this process. You should know that there are multiple applications that are available. We're probably familiar with the nicotine patch, but there's also gum, spray, as well as some oral medications. You don't have to know them specifically as far as what they are, but you should know that there's multiple ways that patients can be treated with it. There is. Why nicotine is, or what nicotine does is it works on a cholinergic receptor site and basically affects the brain by making the individual more alert, more euphoric, and in theory at least improving cognitive performance. The problem with nicotine is that it also has cigarette smoke in it, which has carbon monoxide, which is going to, well, not only kill you, but if you have high levels of carbon monoxide, you're probably not going to be thinking straight. So, nicotine as an agent, not how you gain the nicotine in most cases. A couple other ones that I do want you to be aware of, and these are the non-nicotine substances. Remember, with nicotine, all we're doing is supplying them with a less toxic application of the nicotine through a patch or a spray. These are two other ones that are utilized. One is Bupropion, which is Wellbutrin, which if any of you have or have children who have ADHD, that's a drug that's typically given for that purpose. But it can be used to help stop smoking. How it exactly works, we're not entirely sure. The other one that is out there is Varenicline, which is Chantix, which you probably have seen commercials on. And basically what it does is it blocks those nicotinic receptors within the brain. So what ends up happening is they take a puff of a cigarette and they don't get the charge that they ordinarily would get out of it. So eventually, why am I smoking a cigarette when I don't get the high, the buzz, the positive feeling from it? And hopefully, if you can take that pleasurable sensation that they would normally get from smoking a cigarette away, then you won't have it. Okay. Remember that those nicotine replacement ones we talked about, the patches and the sprays and whatever, they do contain nicotine, which means that you have to be careful how you handle them. Okay? You're also just basically transferring your nicotine dependency from a cigarette to something else. You still have the nicotine habit that you got to get rid of, but this way we can get rid of it in a slower process by withdrawing it. You got. Well, it depends upon the dosage you're talking about.
More along the lines of the chemicals in the cigarettes that we're just trying to...
Yes, absolutely. But if I can get rid of having to smoke, then I still have a nicotine dependency, but it's probably not. I mean, it's a drug. You want to wean off as if at all possible, because the patches aren't cheap.
Right.
Can't wear them forever. But. Okay, and the other side, no.
I'm kidding.
And the problem with Chantix and Wellbutrin, especially Chantix, is it has a lot of behavioral and emotional aspects to the drug that can lead to suicide ideations, as well as having just extremely bizarre dreaming.
So does that kill you the medicine as well?
And this is where those receptor sites are and how it's being blocked by the Chantix. Again, it's an antagonist. It's a nicotinic receptor site antagonist. All right, a drug you should know the name of because we've talked about it before is methacholine. I don't really care that you know how it's supplied and what the dosing is for it, but I do want you to know that it's used as an agent to perform bronchial provocation. So if I suspect a patient has hypersensitive airways, I can confirm it with this drug. It is a parasympathomimetic. You give it, and in patients that have reactive airways, you will see a reaction. Okay? And blah, 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 blah. You got to give a drug after the fast-acting agent. Ethyl alcohol, we used to use this all the time for patients in congestive heart failure. If you remember, as the fluid backs up in the pulmonary capillaries, it backs up into the interstitial space, right? It then moves into the alveoli. As that fluid floods into the alveoli, coming in contact with air, it makes bubbles. And we call that frothing or fulminant pulmonary edema. You actually cough up what looks like pink frothy sputum. The idea being is if I can give them a treatment with alcohol, I can break those bubbles down. You are also inhaling alcohol. Okay? 40% solution, 80 proof alcohol. Some nice pop-off vodka, put it in a nebulizer, and go ahead and go to town. Not used a whole lot anymore. Surfactants we've talked about before. You should be able to recognize that Survanta, Infosurf, and Curasurf are all artificial surfactants. I don't expect you to know the dosages of them, but it is a therapy that is used for patients who are surfactant depleted. Okay. Let's finish up on the cardiovascular agents, and I'll tell you specifically what I want you to know here also. Huh? Well, normally I like to make you suffer, but there's a whole lot of stuff here on this one. How about another video?
Oh my. Really? No.
I don't know what's more disconcerting than the other guy that's wearing a dress.
Trying to hit a golf ball. Shaving cream. I think you need to hit from the forward piece.
Viruses, people.
I didn't pick viruses.
Sorry about that. Oh, shut up. We're not playing E-Dream? Oh. What's your number sheet here? Trade name? Okay. Okay, some of this should be a review to you because we've talked about this when we talked about 10 in 1050. You should know what a inotropic agent is. Has to do with force of contraction. Positive will increase it, negative will decrease it. Chronotropic has to do with rate. Chronos, time. So a positive chronotrope will speed up the heart rate. A negative chronotrope will slow it down. Obviously, the definition of tachycardia and bradycardia are pretty self-explanatory. I think this has probably been beat into you as far as the adrenergic and cholinergic effects on the cardiovascular system. If you forget, go back and look at table 9.1. Blood pressure, we didn't really talk much about this, but it mathematically, if you want to look at it that way, it's the cardiac output times the SVR. So cardiac output is really stroke volume times heart rate, so the blood pressure is related to the stroke volume, related to the heart rate, and related to the vascular tone that is present. Cardiac glycosides, we've talked about them before. These are the slow the rate down. So patients that have an elevated rate, these will have a negative chronotropic effect, but it also has a positive inotropic effect. So this is a drug that we'll commonly use as a long-term management for somebody who has a reduced ejection fraction, somebody who doesn't have a strong heart. Someone has reduced contractility. We talked when we talk about congestive heart failure. I think I talked a little bit about the cart versus the horse. We can either, make the road more flat. We can lighten the load the cart is carrying, or we can give the horse the whip. Right? Now, okay, let me go through it again then. If I have a situation where I have a horse that is having a hard time carrying a load, in other words, a heart that is not generating an effective output, I can alter the preload, I can alter the afterload, I can alter the contractility. I can make the road more flat, get rid of the afterload. I can lighten the load of the cart, reduce the preload. I can give a drug to improve contractility, which means I can give the horse the whip. Vaguely remember this? I know I told you about this. I think you're all high. All right, drugs. These drugs that I have highlighted, I would like you to know the class they fall in. And I will only use the names that are shown there. So you should know that the digitalis or digoxin or digitoxin are all examples of cardiac glycosides that we would give for that inotropic effect. Somebody who has some reduced contractility that want to improve cardiac output, I can do it through giving a cardiac glycoside. Yes? I can also do things that are other examples of adrenergic agents that have a inotropic effect. And we've talked about a few of these. Epinephrine. And the general rule when you're dealing with patients who are in cardiac arrest is all dead people get epi. Two drugs that are kind of like cousins of each other, dobutamine and dopamine. If I have somebody who has a reduced blood pressure that I want to improve their blood pressure, I can place them on an epi drip, I can place them on a dobutamine drip, or I can place them on a dopamine drip. These are all adrenergic agents that improve blood pressure. Somebody who's hypotensive would get one of those drugs. They improve blood pressure by improving contractility. So far, so good? Positive chronotropes. Positive chronotropes speed the heart rate up. Patients who are in significant bradycardias, or let me rephrase that word, symptomatic bradycardias, somebody who's got a heart rate of 40 and their blood pressure is 60 palpable. Well, I would consider that symptomatic. Okay. Somebody who's got a heart rate of 40 because they're a world-class runner, I'm not going to do anything with. They're not symptomatic. Okay. So symptomatic bradycardia and those things like second degree type 2, third degree heart block, atropine sulfate. Atropine. You have to know all the drugs that begin with vowels. Oh, I'm kidding. You got to know all that. So atropine is a drug that we would use to speed up the heart rate. Bloods to regulate blood pressure if it's too high. And there are a lot of them. I'm only going to ask you to know a couple. So if I tell you that a patient's got a blood pressure of 190 over 115, you wouldn't want to give that patient dopamine or digitalis or atropine, but you might want to give them nitroglycerin or nitroprusside, also known as nipride. They're very, very potent vasodilators, which will then lower blood pressure. Another way to manage blood pressure is through the use of beta blockers, specifically propranolol, Inderal. Is anybody on blood pressure medications? I think I've asked that before. A couple of you. Good. You can join me. By the way, scratch Vratmel off there. It's not a beta blocker. It can be used for blood pressure, but not for that purpose. It's not that class. Yes.
Why do they, or maybe some people, get prescribed ACE inhibitors for diabetes for just normal kidney function? If the kidneys are possibly maybe mild stage renal, why would they give them ACE inhibitors?
I don't know.
It's like a new standard. American Diabetes Association had it on the standard.
I couldn't tell you, to be honest with you. But since we're talking about them,
Okay.
ACE inhibitors is another way to do. ACE stands for angiotensin converting enzyme. If you vaguely go back in time, you should remember from A&P that there's this process that goes on where where renin is being released by the liver. It's converted to angiotensin, the renin-angiotensin system, and angiotensin 1 is converted to angiotensin 2. Angiotensin 2 then acts on the arteriolar receptors to promote blood vasoconstriction. Notice none of them are colored.
Okay, good.
You don't have to know any of the names. You should know that ACE inhibitors are another way to regulate blood pressure. Just so you know, also ACE inhibitors prevent the conversion from angiotensin 1 to angiotensin 2. The one that are angiotensin 2 receptor blockers act at the actual vascular receptors, so they work differently. All I want you to know is that use of ACE inhibitors is a way to regulate blood pressure. Leave it there. So I can use vasodilators, I can use beta blockers, I can use ACE inhibitors of some kind.
And then this one regulated by law.
Yeah, if I got somebody who has a long-term blood pressure problem, like me, we'll end up having some mechanism to control it. If somebody has a low blood pressure, and it's something where I want to raise their blood pressure by actually causing some alpha reaction, I can do that by using a drug called norepinephrine, also known as Levophed, jokingly called Leave 'em Dead. It's a potent drug. And we could also use an inotropic agent, as we talked about before. So if I said the patient's blood pressure was 60 over 0, or 60 palpable, I would not use nipride. I would not use an ACE inhibitor. And that's the way the question will be worded. I want you to be able to identify which drug would be appropriate to use in a particular instance.
Atropine?
I would not use atropine. Atropine only controls rate. Someone who is having angina or angina, it's basically where you end up having a reduction of coronary blood flow. I'm having chest pain, so I need to improve blood flow to the myocardial tissue. Typically what is used is nitroglycerin, a nitrate. You don't need to know it for now, but I will tell you that you will need to know it eventually, is that all nitrates have as part of their side effect methemoglobinemia, an increase in the amount of methemoglobin levels. So patients on chronic nipride therapy will actually have reduced arterial oxygen saturation secondary to the medication converting normal hemoglobin into methemoglobin. And what's methemoglobin? Ferrous to ferric. It's useless hemoglobin. It's an anemic hypoxia. Okay. Beta blockers and calcium channel blockers can be used also, but I like to use them in another spot, so let me talk about them later. You probably have never seen this slide before or know anything about the conduction process of the heart. If you don't, you better before your exam this afternoon, for those of you who haven't taken it all already. But again, origin is the sinoatrial node. The impulse travels through the atria, converging at the atrioventricular node. Passes through the bundle of His. For my purposes, I just call it the whole thing the AV bundle. Then goes down through the bundle branches, right and left, into the Purkinje fibers, which innervate the myocardial wall itself. When we talk about something having an ectopy, an ectopic focus, we're talking about the beat originating from somewhere outside the sinus node and not following the normal pathway. This is where we get those irregular beats. PACs, PVCs, PJCs, MOUSE. Okay. You probably have never seen this slide before either, but you know there's different waveforms that occur. PQRST, PR interval, QRS. Okay. We know that what the purpose of the P wave, the T wave, and the QRS complex is. If there's something where that conduction process is not working right in the sense that there's dysrhythmic, and let me be specific about what I'm talking about when I'm talking about dysrhythmic on this slide, is I'm talking about ectopic beats. Okay, so if I have a premature ventricular contraction, and I think you remember that there's times where PVCs are more problematic. come more than 6 per minute, when they come in couplets, when they come with friends from different neighborhoods, right? When it's on or near the T wave. These are all bad things that can happen. If I had a situation like that, I would give an antidysrhythmic, an antiarrhythmic, like lidocaine, procainamide, amiodarone. I don't know why that word is so hard to say. Amiodarone. Adenosine, verapamil. Now some of these are primarily atrial dysrhythmic agents. Some of them are primarily ventricular dysrhythmic agents. Amiodarone is one of the nice ones because it kind of works on both. It has some control over an SVT, a supraventricular tachycardia, and it's definitively beneficial in the case of ventricular tachycardia or ventricular fibrillation to raise the fibrillatory threshold to facilitate defibrillation. What's that? Yeah, it kind of has, it both works for an SVT and for a VT. The other ones, the adenosine and the verapamil, primarily are used for SVTs. Lidocaine and procainamide are primarily older drugs, but they could be used for more of ventricular tachycardia. Procainamide has a little bit of atrial too, but. And you should be able to memorize. Yes, sir.
Question for you, ventricular tachycardia.
Yeah.
If there's a pulse, if there's no pulse, either time you use those drugs?
Well, if there's a pulse, you would definitely try to use the pharmacologic agent as quick as possible. The problem is patients don't stay in pulsed VTAC very long. They're going to decompensate real quickly. Once they're in pulseless VTAC or in VFib, in both cases, amiodarone is kind of been looked towards being the primary antiarrhythmic that is used. And in that case, especially with VFib, it's not so much to try and break the dysrhythmia, it's to raise the fibrillatory threshold to be able to more easily defibrillate them. I don't think so. Couple of drugs you should be aware of, and if not, I believe Mary has talked about them, so it would be fair game anyways. But these are drugs that our patients we use as an anticoagulant. They'll talk about them being blood thinners. They don't really thin the blood; they just prevent clotting mechanisms from happening. Heparin and Coumadin are the two primary agents that end up using. And they do have antidotes. I don't expect you to necessarily know them, but there are antidotes for those. So if you had a heparin overdose, there is a mechanism that you can control it with protamine sulfate. But obviously, these are ones that are going to have a hard time stopping bleeding. So for a blood gas sample, you would need to hold for a prolonged period of time. On the other end of the spectrum are ones where we give to break up clots. These are drugs that, if clotting is occurring and we didn't want it to happen, say in the case of a coronary thrombus or in a cerebral thrombus, and I want to break that clot up, I can give a drug like TPA, tissue plasminogen activator, what the TPA stands for those who really care. Urokinase or streptokinase. Usually TPA is the more common one. Either as activates or renovate. Both of them are ones that are commonly used. So if you come in with a acute myocardial infarction that is evolving, if we want to try and stop that process before I can get you to the cath lab, I can give you a drug like a thrombolytic. If I am fortunate enough to catch you having a stroke in the first few hours of that stroke, I can give you assuming the stroke is not a hemorrhagic stroke, which this would not be a good drug to give in that case, I can break the clots up by using a PPA. Last group of drugs that I want you to be aware of are the pulmonary vasodilators. And we'll talk about these a little bit more when we talk about management in neonatal medicine. But inhaled nitric oxide, NO, or what is the abbreviation, I guess, would then be INO. Nitric oxide is a selective pulmonary vasodilator. How it works is really damn cool. We'll talk about it later. But prostacyclin's another one, and a drug called iloprost, better known as Ventavis. This is a brand new drug, relatively brand new. Lots on that slide. All I want you to know is that iloprost is a pulmonary vasodilator. That's all. If you happen to work in a center that has a pulmonary hypertension clinic, it's kind of a specialized place where there's probably a handful of them in southeastern Michigan. Unless you're working there, you'll never end up seeing this drug used. At least now. Who knows later. That's your